Is my screen visible, boss?
Yes, yes.
I'm audible?
Yes, yes.
Okay. So today I'll be talking about only the history and the examination part. We are not going to discuss the pathogenesis of all the diseases and all. And then there'll be a relay of the sonoanatomy and how to perform the procedure by Dr. Chinmoy and Dr. Devjyoti. Okay. So now, in order to understand any joint, okay, like when I'll be taking your elbow, wrist, your knee, ankle. So in order to understand how exactly are we supposed to take the history, why exactly the history is important, right? So we need to understand the anatomy, right? Because if we know the anatomy properly, we know what structure is going to be the pain generator and how are we supposed to test them. So that's why listen to this 4 or 5 slides very, very carefully, because shoulder joint is one of the complex joint of our body. Okay. And you have the most, I should say, the commonest musculoskeletal joint involved in our body is your shoulder after your back pain. So you need to be knowing the anatomy. You need to be very particular about the anatomy, right? So let's see. So when we are talking about the shoulder joint, I hope all of you are able to see the arrow moving on the screen, right? So just concentrate on this arrow. So when we say shoulder joint, this is a ball and socket joint. So what exactly is the ball? This head of the humerus is going to be the ball, right? And what is the socket? This glenoid, okay, is a part of the scapula, which is the socket. So it's a ball and socket joint, fine. And this is the hyaline cartilage, which is there over the head of the humerus. And if you look at the head, you will see that the head is bigger as compared to the socket. So this is not very stable joint. So that's the reason you have lots and lots of things to make it stable, right? So we'll be learning about all those things in a stepwise manner. So first learn the anatomy of the upper part of the humerus. Lower part I will be discussing when I'll be taking your elbow joint. Fine. So this is the upper part of your humerus. Okay. So what all we have in our upper part, we have learned that this is the head. Head will be covered by your articular cartilage. And that articular cartilage is hyaline cartilage. Hyaline cartilage in ultrasound is going to be homogeneously hypoechoic, right? So you will be seeing this cartilage in ultrasound also. Fine. So you have the head will be covered by the hyaline cartilage, and then you have the neck. So their neck, you have two necks. One is your anatomical, one is your surgical. Surgical is at the junction of your head with the shaft, and neck is lying adjacent to your head. Fine. Then you have two tubercles. One is your greater tubercle and then the lesser tubercle. In between these two tubercles, you have you have a passage in between these two bumpy things. Okay, so one bumpy thing is your greater tubercle and one bumpy thing is your lesser tubercle. In between these two, you have a road. Remember it like that, right? So now this road has got a lateral margin, lateral lip, okay, and the medial. Medial will be towards the lesser tubercle and lateral will be on the medial side of your greater tubercle. Now, what is the importance of knowing this, right? You have a floor here. So you have two roads. Remember, two fences are there, and this is the floor. Why is it important? Because this is the one which is going to lodge your long head of your biceps tendon, right? And this biceps tendon, you can just have a look how it goes inside the inside your intertubercular sulcus, right? And this tendon is going to be held there by your transverse ligament. That's why when you will put your probe there, you will be able to see two bumpy things. One bumpy thing is going to be your greater tubercle, another one is your lesser tubercle, and then you will be able to see your long head of biceps tendon. Fine? Right. Okay. Moving to the next one, just have a brief idea about the anatomy of the scapula, because this is also very, very important to us, right? So this is the scapula. Scapula has got two surfaces. If you are just like you're just looking at me, so now the portion of the scapula which is facing you is the costal surface, okay, and the one which is at my back is my dorsal surface. So this costal surface will be having a fossa, and this fossa is known as subscapular scapularis fossa. Fine. And you have an a projection there, and this projection is known as coracoid process. So you will be, if you want to see the subscapularis muscle, so this will be going like this, and this will be getting attached to the lesser tubercle, right? So this, if you want to look for this muscle, you have to look from the anterior aspect. Now, if you go to the posterior aspect, you have a spine, right? This spine is a border, you remember, it's like something protruding from the surface of the scapula, and which is dividing it into supraspinous fossa and infraspinous fossa. And this spine later on becomes your acromion, and which will be articulating with your clavicle. Okay, now this is your glenoid. In some books, they have written it as glenoid fossa. Some books, they have written it as glenoid cavity. But overall, you remember it, it's the glenoid, okay? And this one is the one which will be articulating with the head of the humerus, right? And this glenoid has got a fibrocartilage. What you are able to see in your purple color is your labrum. What is labrum? This is just a fibrocartilaginous rim which is present there around the glenoid, okay? And on the top of that, you're going to have your capsule, fine? And what we have learned that the long head of the biceps tendon lies in between the intertubercular sulcus. So this long head, it takes its origin from your supraglenoid tubercle. And you see this tubercle is here, and this is your capsule. That's why the long head of the biceps brachii is intracapsular. Okay, all the other rotator cuffs, they are extracapsular, but this long head is intracapsular. This is very, very important for you to remember. Okay, now if you look at this scapula from the back, okay, this is the superior border. This was the fossa. Okay, so this is the superior border of your scapula, and this superior border has got a dip. Okay, means this superior border is, there is a depression there. So this depression is known as suprascapular notch, and when they will be showing you the sonoanatomy, you will be looking for the suprascapular nerve and the artery in this notch. Fine. So this notch is present on the back side, right? So when you want to look for the suprascapular nerve and the accompanying artery, you have to visualize it from the back. When you want to look for the supraspinatus muscle, again from the back, infraspinatus, again from the back, acromion nicely, you can just trace it from the back to the anterolateral aspect. Fine. Coracoid is again on the anterior surface, and subscapularis fossa is again on the anterior one side, right? So that orientation is very much important. Now we have talked about the capsule. So this is how the capsule looks like. Okay, now this capsule inside will be lined by your synovial membrane. The red one which you are able to see is your synovial membrane, right, which lies inside your capsule. Fine. Okay, now coming to the muscles, we have already learned that on the anterior aspect, we are going to have the subscapularis fossa. So this fossa, this muscle, it takes its origin from this fossa and it attaches itself to the lesser tubercle. If you go to the posterior aspect, you have your supraspinatus, which will be there in your supraspinatus fossa, and this will be there in your infraspinatus fossa. Fine, the infraspinatus muscle and teres muscle will be taking its origin from the lateral border. Now, what you need to remember here is, if you look at this greater tubercle, okay, this greater tubercle has got three facets: superior facet, middle facet, and inferior facet. These four are the rotator cuff muscles, okay? Anteriorly subscapularis, and posteriorly you have supraspinatus, infraspinatus, and teres minor. Now, if you look at the arrangement of this muscle, this is on the top, this is at the middle, and this is lower, right? So this is how they will be attaching themselves on this greater tubercle, okay, of your humerus, on the facets which are present there on the top of your greater tubercle. Fine. So here you will be having the attachment of supraspinatus, then infraspinatus, and then teres minor. Okay. Now, two more muscles which you should know. One is your deltoid. Deltoid, you have an anterior fibers, middle fibers, and then the posterior fibers. So when these three fibers, they are the one, they will be covering the whole of our shoulder joint from outside. Okay. Then you should know this muscle, pectoralis major, because this is one of the adductors of your shoulder joint. Okay. So this muscle arises from the clavicular portion of your clavicle and the ribs, and it attaches itself on the intertubercle sulcus, as you can see here. Okay. So lateral lip of that. Someone is unmuted. Please mute yourself. Just learn these muscles if you can. Okay, you have a coracobrachialis, which, see, you can remember it with the name coracobrachialis. Brachialis means arm. So it arises from your coracoid process and it attaches itself to the mid shaft of the humerus. This we have learned. The biceps has got two head, long head, which arises from your supraglenoid tubercle, which is present there on the top of your glenoid. Then you have a short head, which arises as a conjoined tendon along with your coracobrachialis and from the coracoid process. So this short head is like, separate, and this long head is separate, both of them. Then they combine to form a tendon, which is getting insert, which will insert on the posterior aspect of the radial tuberosity. Okay. Now, you should know the muscle which are there in the back also. So one, we have trapezius. Trapezius has got three fibers. You have the descending fibers, you have the transverse fibers, and the ascending fibers. Then you have your rhomboid major and minor. Okay, they are the retractors of your scapula. Okay, and the upper fibers of your trapezius along with the levator scapulae will be elevating your scapula. So if you have a spinal accessory nerve entrapment, that time what will happen? The patient will not be able to shrug the shoulder. Okay, this IB will be learning, but just have an orientation of all the muscles which are present there around our shoulder joint. Okay, so muscles we have learned, all the parts of the bones we have learned. Now we should know the bursa. What are bursa? Bursa are sac, okay, which will be collecting the fluid, and this will be present whenever the muscle will become a tendon and whenever it has to move around the bone. Okay, so that you will be having a frictionless movement. Otherwise, what will happen if you do not have this bursas and all? What will happen? There will be a gliding motion of the muscle against the bone, and you will be having more amount of wear and tear of that muscle, right? What is important for us as in the basic course is this subacromial bursa. You have other bursas. You have subscapularis bursa, which will be lying beneath the subscapularis muscle. You have coracoid, you have subcoracoid bursa, okay, this one which will be lying on the top of your subscapularis. So these are for advanced courses. You do not remember them. You remember this bursa because this is very, very important. Okay. Now just try to understand how exactly this bursa is located. So we have learned the spine will become an acromion. Okay, so it will turn and then it will be articulating with the clavicle, which is coming from front. Okay, so this bursa will be lying beneath your acromion. Okay, so this is your acromion, this is your bursa, and then you are going to have your supraspinatus muscle. Okay, so whenever you are trying to abduct, so this bursa will be preventing the supraspinatus muscle getting having friction with the acromion. Okay, so this is the bursa which you should remember because subacromial bursitis is very, very common. Okay, fine. Ligaments, ample amount of ligaments are there. Okay, you have the coraco. What you need to remember is this ligament, coracohumeral ligament. Recently, it has gained lots and lots of attention because the fibrosis of this ligament, coracohumeral ligament, results in adhesive capsulitis, which in the local term we call it as frozen shoulder. Okay, so coracohumeral, always try to remember the ligament. What I have taught in my basic ultrasound class, ligament is from one bone to another bone. So knowing the name of the ligament is very easy. Okay, so if it is from coracoid process to your humerus, it becomes coracohumeral, right? If it is from your coracoid process to your acromion, it becomes coracoacromial. Okay, if it is from your acromion to your clavicle, it becomes acromioclavicular. So for your basic course, you need to remember these these ligaments very nicely. One is your acromioclavicular ligament, one is your coracohumeral ligament. Okay, because if you have the rupture of this ligament, you are going to have the movement of clavicle distant from your acromion. Okay, so that's why you should know if there is a problem with this ligament. This is not our case. We need to refer a case to the orthopedic surgeon, right? And there are various others from the coracoid to the clavicle. You have another ligaments, and you have the glenohumeral, the ligaments also from the glenoid to the humeral. For the time being, you just remember that there are other ligaments also present. But for the basic course, do not forget this coracohumeral ligament. This is very, very, very important. Okay, and this is from your coracoid process to your humerus. Okay, fine. So history taking, this was all about just to make you orient about the anatomy, so that when we are taking the history, you will understand what exactly we are talking about. Fine. So history taking, ample amount of pain generators are there. We have learned about the muscles. So muscles can be the tendons, they can be the pain generator. Muscles can be involved in your myofascial pain syndrome. You have the joint have got the articular cartilage, so they will be subjected to your degeneration, right? So there are bursas are there, so you can have the enlargement of the bursas, right? So many causes are there, but today we will learn how to come to a conclusion, okay, but just by taking the history and doing the examination. So that is the motto of this class. So let's see. Before beginning the class, I would like everyone to remember this 5 in your, just get them imprinted, inside your brain very nicely, so that whenever you take the history of any patient, these things should be there at the back of your mind. They are the red flags. They are there. We are not the person. We should not be the person to be treating them, right? We should be sending them to our colleagues. Like, if a patient who has sustained a trauma is having a fracture, obviously, as a chronic pain physician, we are not going to deal with that. If there is a dislocation, we are not the one to reduce it, right? If there is an infection, septic arthritis, we are not the one to treat them. If the patient is having, suppose, because I'm talking about the shoulder today, so you have a pancostal tumor, so we are not the one to treat them. And if there is an unexplained motor and sensory loss, means you are not able to explain it as an entrapment neuropathy, you are not able to explain it as a disc prolapse, a cervical disc prolapse, please, they are not the cases for us. So just keep those things in your mind, because these things, they need immediate management. We are not supposed to delay them, right? So just keep them at the back of your mind, right? Okay, so this is the mnemonic I usually teach. Okay, so first history, what we are going to take is the pain history, right? Because we are pain physicians, so that is, the patient is going to come to us with pain. So remember this mnemonic, and believe me, if you will use this mnemonic at least for I think 20 or 25 patients, it will be there always in your mind, and you will never even miss a step of taking a pain history. Okay, so this, remember it like it's a very nice mnemonic: Ola car night ride. Okay, so you are in an Ola car and you are going for a night ride. That is how you should remember it. Okay, now just remember the expansion of this mnemonic. O here. Somebody wants to say something? Then please mute yourself if you do not have anything, because that interrupts the flow of the class. So if you have any question, you write down in the chat, or you can just unmute yourself and you can ask me. But unnecessarily, please do not unmute yourself. Okay, it's a request. Then O here is your onset. Fine, we will be discussing each and every part. So just remember, O here is your onset. Okay, LA is the location. Okay, C here is the character of the pain. A here is your aggravating factor. R here is your relieving factor. And night here is your night pain. And this ride, because when we go for a ride, we do not stop, until unless we just go for 1 kilometer, 2 kilometers. So ride becomes your radiation of pain. Fine. So onset, location, character, aggravating factor, relieving factor, night pain, and radiation. And I'll be asking any one of you to again explain me the mnemonic once I finish up with the history. Okay, fine. So now we are just thinking that one patient has come to us. He is having some kind of only shoulder pain, and today very specific, because usually what happens if you see a patient of shoulder pain, you will be do not think that whatever I'm going to tell you exactly like that you will be getting a patient. Okay, it is not like that. If you are into the clinical practice, you can have enormous amount of symptoms going together, so you need to sort them out. Okay, but this is the basics. If you will remember it, it will be making your diagnosis, clinical diagnosis, very easy, right? Okay, so one patient has come to you. Okay, he has come inside your chamber. I'm not talking about all those the gate and all, because there will be a separate class by sir where he'll be mostly taking all the basic history parts. So today I'm not discussing all those. I'm very specific about the shoulder. So we are going to discuss only the history, which is very much specific to the shoulder and nothing else. Okay, so now the patient has entered inside your chamber. Okay, you just have a look to the, you're just having an eye contact with the patient. Okay, so that time, obviously, by looking at the patient, you will be able to make out whether the patient is young or whether the patient is old, right? So if the patient is young, think of instability and the labral tear gonna be the causes. Okay, fine. So young age, these two are the most common causes for shoulder pain. One is your instability. Instability means the patient will feel like, as if the shoulder is gonna come out. Okay, so that is the instability. Labral tear, what we have learned, the labrum, which is there in the glenoid cavity, okay, the glenoid and the fibrocartilaginous rim. If you have a problem with that, so those problems are the problems of young age. Okay, now if the patient looks like to be a middle age, like something around your 30s to 60, okay, think of adhesive capsulitis, which is basically the fibrosis, okay, of your coracohumeral ligament, and now also the inferior capsule, okay, the inferior portion of the capsule. Okay, this you can go back and read, but for the time being, just remember this is just a fibrosis of your ligament, which we have learned from our anatomy class. Tendinopathy, now these terms have been changed, tendinitis. So you should be very much particular, and I think I should tell you. See, tendinopathy is a very broader term, okay? And when I'll be taking your common flexor tendon and common extensor tendon, I will be discussing about it further. But for the time being, you remember that tendinopathy is a broader term, which has got several classifications, okay? Several subdivisions. So when we say tenosynovitis, we do not say nowadays tendinitis, we say tenosynovitis, okay? Tenosynovitis means the tendon, which is going to have a sheath. You have the accumulation of the fluid inside your visceral and the parietal layer. Okay, you have the collection of the fluid. So that is your tenosynovitis, means tendon synovial, inflammation. When I say tendinosis, tendinosis means I have a problem now inside the tendon, means the collagen fibers which are present inside the tendon, I have a problem with that, right? When I say partial tear, how can you remember a partial tear? I have made a wall of brick and I have removed some brick. Okay, so that is partial tear, means some fibers are lost. When I say complete tear, means I have broken the wall completely. Okay, so that is complete tear. So when you will be trying to stretch that muscle, you will be seeing that both the ends, they are moving apart, and we can see all this with ultrasound. Okay, so tendinopathy is a broader term. So you can have a tenosynovitis, you can have a tendinosis, you can have a partial tear, you can have a complete tear. So when I'm saying tendinopathy, it means 4 of them. Fine. Then again, the rotator cuff tear. And if a patient who is quite old, something around 60, 65, think of the tears more. Okay, tear, and of course the degenerative arthropathy. You have seen that cartilage, so that cartilage is going to get degenerate and you're going to have arthritis. Fine. So always remember, young age, it is instability, it is labral tear. If it's a middle age, think of adhesive capsulitis, tendinopathy. If it is older individual, think of all the rotator cuff tears and arthritis. Fine. Okay, now the second question, what you will ask to the patient. Okay, now the first question, sorry, you will be asking to the patient, because now you have an eye contact. Okay, you have an idea inside your brain. Okay, what it could be, just a rough diagnosis. Now ask the patient whether it is only one shoulder which is paining or it is both shoulders which are paining. Mostly, if it is only one shoulder, think of degenerative arthropathies. Okay, and think of rotator cuff tendinopathies and tear. Okay. And if it is bilateral, think of some myopathies, okay? And of course, the inflammatory arthropathy. This is just rough. You can have a varied presentation also, but this is just because we are learning, we are at the basics of our pain management. We have just entered into the pain medicine. So we should remember them roughly, okay? You can have a varied presentation also, but for the time being, remember it like that, fine? So now you have asked. The second question will be, how long you have been into this pain? If the patient says, recently only, yesterday night only, I fell down from the bike. So that is acute, right? If he says, this is like hot, I'm touching it, it's very hot, it's very painful, and suddenly it has developed, think of some kind of infection. If a patient says, you know, I had this pain, it was there for quite long, and I've been living my life very nicely, but don't know, doctor, suddenly excruciating pain from the last night, it's unbearable. Think of calcific tendinopathy, okay? The calcific deposits, which is also a part of the degenerative process, which has deposited on the tendon itself, that will be getting absorbed. So that absorption phase is gonna be very, very painful, okay? So think of that. So this is acute on chronic, because the pain was chronic, but now it is acute. So it is acute on chronic, okay? And of course, the disc prolapse, the radiculopathies, they are gonna present with the sharp shooting pain of sudden onset. If the patient says, no, doctor, I'm having this pain for the last 3-4 months and I'm just taking some medication, just living my life, think of rotator cuff tendinopathies. Means now it is the tendinosis, or it is the partial tear, or we are progressing towards the complete tear. So that progression phase we are, or you think of any degenerative arthropathy. Fine. So first was the site whether it was unilateral or it was bilateral. Second comes to your onset. Okay. Now, third question, ask the patient, where exactly are you feeling the pain? And remember this pictures very nicely. This is surely going to help you in your diagnosis. Okay. So see, if the patient, that way this lady is holding, okay, if the patient is telling, I'm having this pain, means this is over the deltoid area, like this. Okay, I'm having this pain, doctor, like this here. Think of some subacromial pain. What we have learned, this was the acromion. Beneath that, you have the bursa. Beneath that, you have the supraspinatus tendon. So some pathology over there. Okay, either it could be a bursitis, either it could be the tendinopathy of your supraspinatus area. You could have something related to your biceps. Okay, so it could be anything, but we label that pain as subacromial pain. Okay, see. Fine. So this, and of course in C5, C6 nerve root lesion also, you're going to have the radiculopathy, you're going to have pain from here till here, right? Now, if the lady is pointing typically, so if she is showing like that, means she's not trying, she is not able to localize the pain. So the pain is diffuse over this area. So the subacromial pain is going to be diffuse and it will be over the deltoid area. But in some cases, you may have the radiation up to the elbow, and in rare of the rarest, you can have up to the forearm, right? Okay, so if she's trying to point you, okay, doctor, I am having the pain, typically with one finger, she's pointing on the top of your shoulder, think of AC joint arthropathy, okay? If she is telling you, he or she is telling you, oh, I am having the pain over this anterior shoulder, what we have learned, anterior shoulder, what we have our subscapularis, We have your coracoid, so you can have a subcoracoid impingement. We have learned the biceps is going like that, so you can have a biceps pathology. And of course, the rotator cuffs of the subscapularis is there. So you can have some problem with the rotator cuff, which is going to be here. Like rotator interval is somewhere here, but of course the pain, because you can have a diffuse pain in this condition. So it could be from either of the ones which I have listed. Okay, now coming to the back, suppose she is not having any pain over here, she is having pain over this. Now look at the movement of my arrow. If she is showing you I am having pain here, so what was that? That is the upper fibers of the trapezius which are going and getting attached, right? So you can have a myofascial pain syndrome of your trapezius. It could be a referred pain from your cervical pathology, which we are not dealing with today. Okay. Now, if the patient says, I'm having pain here also, and I'm having pain in the interscapular area also, so that time you can think of the entrapment of your spinal accessory nerve along with your dorsal scapular nerve, right? Dorsal scapular nerve is the one which supplies your rhomboids, and your spinal accessory nerve is the one which supplies your trapezius, right? And trapezius help in the elevation of your scapula. Right, so you can have a myofascial pain syndrome of your trapezius, you can have a myofascial pain syndrome of your rhomboids, and you can have them separately, you can have them together. Okay, supposedly the patient is saying, no, I'm having pain like this, whole deep seated, I don't know from where it is coming, I'm feeling as if something is coming from the inside the joint. Then inside the joint, what you have the cartilage, you have the labrum, right? You have the capsule. So think of any labral tear or arthritis. Okay. Scapular pain, I have already told you about this entrapment. So interscapular region you are going to have. Fine. So this much of history you have taken. Now, what you need to ask is, you ask about the radiation of pain. Like I have told you, in subacromial pain syndromes, you can have the radiation up to the elbow, but most of the times you will not have the pain beyond this shoulder joint unless it's a subacromial pain, right? So if it is extending beyond, think of this pain as if coming from the cervical region, right? Not from the shoulder. Night pain will always be there. How, like suppose there is a tear of the rotator cuff, so that is going to be very painful. If it's an inflammatory pathology, you have the collection of the fluid, so that fluid is going to give that throbbing pain, whenever they'll try to sleep on that side. So ask about the second thing, radiation, night pain, and then you should ask about the character of pain. Usually, always remember, if it's a joint pathology, you are going to have the dull aching pain. Sharp shooting pain, usually you'll have referred from, you have that disc prolapse compression of the nerve, so you are going to have that, but they have found this pain even if you have the involvement of your long head of biceps. If you have a tenosynovitis of your biceps tendon, that time also in shoulder pathology, they have found the character of the pain to be like a sharp burning pain. So if the patient says, I'm having something like a sharp burning pain, just do not think of cervical pathology. It could be a tenosynovitis of your biceps tendon. Fine. Ask them, which is the thing which is aggravating your pain. Okay, so the aggravating your pain, patient is not going to tell you, like when I am doing the overhead activities, my pain is increasing. How the patient presentation will be, if she is a lady, what she will say that whenever I'm trying to hold the jar from like the shelf which is there in my kitchen, I'm not able to do it. If I want to comb my hair, I'm not able to do it. Okay, the man will say, if somebody will ask me to just get hold of something which is on the shelf and bring it down, I'm finding it difficult, right? So overhead activities will be increasing the pain if you have rotator cuff tendinopathies or the acromial joint pathologies. Fine. The body level activities will be increasing the pain if you have the degenerative and the inflammatory pathologies of your glenohumeral joint. Do ask about the relieving factors. Sometimes what the patient will say, like suppose he is having a glenohumeral arthritis or inflammatory arthritis. Either whenever I'm having pain, I just go to the medical shop, I get them some medication, I just have those medications and my pain is gone, right? So that is the relieving factor for that patient. Sometimes they will say, oh, if I'm resting, I'm fine. Then somebody will say, okay, if I'm not able to eat it like this, what I do, I lift my hand like this and then I eat, I'm able to eat. So that is the way they will get accustomed during their long time of suffering. They just try to accustom to with their pain. So you need to drag it, you need to keep on asking the history so that the patient will be telling you it rightly. And do not forget, if the pain is on the top of the shoulder, obviously it can come from your abdomen, it can come from your heart, or it could be a post, the laparoscopic surgery. Post that, you can have a pain at the top of the shoulder. So do keep this thing in your mind when you're taking a history. Okay. Now, what we have learned, Ola car night drive, that was for the pain history. Now, what you need to remember with the associated symptoms, you remember it like WIP. WIP is World Institute of Pain. SC is section. So this should be completing the whole of the pain history. Okay. Now remember, what is W? This is the weakness. Okay. So weakness, you need to find out whether it's an absolute weakness or whether it's a relative weakness. What is absolute? Absolute means there is some pathology with the nerve. The nerve is gone, so the muscle is now atrophied. Okay. What is relative? Now I am having pain in my shoulder. I don't have problem with my muscle, but I'm having pain. That's the reason I don't want to move my shoulder. So that is relative weakness. It is because of the pain you're not able to move it. Fine. It is not because of anything else, right? So weakness. What is I? I is instability. Okay, if you don't have that fibrocartilaginous rim, there is some problem. So your joint is going to be unstable. Fine. Paresthesia are abnormal sensation. Usually you will get it whenever you will have the nerve entrapment, tingling sensation. You can have the numbness, you can have pin and needle like sensation. So abnormal sensation that will always be specific of your nerve involvement. Okay. Do ask the patient that when he gets up in the morning, do the joint feel stiff? Okay, means is he finding a difficulty in moving the joint? So that stiffness will always be there if there is some problem with the articulating part. Okay, and do remember that labral tear and instabilities do have clicking sounds. Okay, the patient will say that. And usually what we have learned that labral tear and instability will be there in the younger individuals. So they will be complaining that, I do feel some amount of sound whenever I'm trying to move my joint. So that's all I think about the history. So again, okay, few more is there. Do ask about the past musculoskeletal history. Past musculoskeletal history means like the patient might be having, like the patient might have had some pain in the shoulder, and it subsided. Now again the patient is coming with pain. So just ask about whether he had the similar pain, or like maybe a rheumatoid arthritis patient who is having pain, the disease went into the remission phase, now again he's coming up with the pain. So do ask about the musculoskeletal history, whether he is having pain only in one joint or the multiple joint. That is also very, very important. Medical history, specifically the diabetes and the hypothyroidism, these are very important because they are the reason for the adhesive capsulitis. It has been seen that adhesive capsulitis is more common in the diabetics and the patient who are hypothyroid. So do ask about these two history, and if you'll ask me what exactly is the reason, the pathogenesis is not clear about it. Okay, do ask about the drug allergy to the patient, because like I have seen in my 6 years of my practice, I should say that I have seen more than 20 patients who are like allergic to your NSAIDs. Okay, do ask this history, that whether after taking any of the painkiller from the medical shop, they won't, have you ever developed any kind of itching, something like that. Do ask about this history, and do write in your prescription that no history of drug allergy. Do ask about the family history, whether somebody is having the same pain or not. And we will be having an elaborate discussion on this in our subsequent classes. So now this is the summary. What you need to remember is these two. You want to get an Ola card, night ride. Where you want to go? You want to go to the WIP section. So you just write it down in one paper, or you can just write it down in the pencil in your prescription, and just keep on asking the leading question when you are starting to take the history. Because as I was from an anesthesia background, if you'll ask me, yes, it was difficult because I have never examined shoulder. But over a period of time, if you practice it, if you practice the
No sound, ma'am. No sound. Not audible. Not visible.
Okay, I think there was no electricity. Suddenly it went off. Okay. Boss, I hope I'm audible now.
You are
Okay.
audible.
So moving to the examination, and actually I thought of demonstrating it, but since there is no current in my hospital, suddenly the electricity went off. So no worries, we will just see the examination now, and maybe in my next class, I will be demonstrating it again to you. Okay, so now just listen. Okay, again, we have a mnemonic for that. Okay, before starting that, how I say is whenever you are trying to examine the shoulder, three things you need to remember. One is your look, then is your feel, and then is your move. Okay, look means you should be asking the patient to remove the clothes up to the chest, okay, like which is shown there in the picture, and then you should be examining the shoulder. Do not examine the shoulder if the patient is, covering with clothes, because you will not be able to see most of the things, right? Okay, so how you need to examine is you need to look it from the front, you need to look it from the side, and you need to look it from the back. Now, what exactly you should be looking at, right? So you should be looking for any surgical scars, you should be looking for any swelling, or see this shoulder is having a rounded contour, right? So if you are not able to see the rounded contour of the shoulder, there is some problem, you're able to see the squaring of the shoulder instead of the rounded thing, then think of some anterior dislocation. Look for the muscle wasting over, like look for the muscle wasting of this deltoid area. And of course, this is the spine of the scapula. You're able to see it, I don't know, but this is the spine of the scapula. So look for the muscle wasting above or below the spine of the scapula. Okay, and just have a look to the skin, look for any color changes or any rashes. What happens if I've fallen down from the bike? I'm going to have some scratches over there, right? Sometimes the patient will not be telling the history that, yesterday I fell down from a bike. But if you just look at the shoulder, you will be seeing that those scratch marks, right? So that is also going to give you a clue. And of course, look for any winging, means the medial border elevation, medial border prominence or from the back. Okay, so this, if you want to remember it, that is the SLAMS wing. Okay, S is for your surgical scars, L is for your lumps, A is for your abnormal posture or asymmetry, M is for your muscle wasting, S is for your pathologies over the skin, and then wings is for winging of the scapula. Okay, so now we have looked at the skin. Now what you need to do, you need to palpate. So you start palpating from your sternoclavicular joint, keep on palpating, look for any deformity over the clavicle, then come at the backside of the patient, and then you keep on palpating. You will be reaching up to you will be just palpating the acromion, and then you will be reaching to the spine of the scapula. Fine. What else you need to palpate is you need to palpate this bicipital groove. Look for any myofascial trigger points in this muscle, either the trapezius or the rhomboids. And how are you supposed to palpate? If these are the fibers, your palpating fingers should be perpendicular to these fibers, and you will be able to see taut bands, okay, in that muscle, means something which is nodular like a thing, you will be able to see there. Fine. So palpation, you need to palpate the bony things, and along with that, you need to palpate the muscle. Fine. Now, what these are the range of motion. Fine. You have the flexion. Flexion means, see, if this midline is my sagittal thing, okay, and this one is the coronal. So this is the coronal plane, and this is the sagittal plane. From the coronal plane, if I move my arm 20 to 30 degrees forward, that becomes my scapular plane. Okay, just try to understand, and maybe in the next class I can show you, but still for the time being, just look at the pictures and try to grasp. Okay, so when I'm saying flexion, flexion means I'm elevating my limb in the, okay, I'm elevating Dr. Jude Reshma. Please mute yourself. Okay, so this means I'm elevating my limb in the sagittal plane. Okay, extension is I'm moving it backwards. External rotation is again I am opening. Okay, external rotation, if you see the humerus, the head will be going away from the midline, and when you say internal rotation, this will be moving towards the midline. Abduction, when I say I'm lifting it in the coronal plane. Horizontal adduction means I'm bringing it towards the body. Okay, means I'm bringing it towards the body, and if I'm moving it away from the body, that is abduction. Fine. Okay, now if once we have just done the active, we have demonstrated the active thing, we have what you need to do is you need to ask the patient that follow what I am doing it. Okay, if the patient is able to do it nicely, it means the active motion is perfect. If he is not able to do it, then you need to support it. Okay, now once you have tested the active motion, the second thing is you need to go for the examination in this manner. Okay, so what is the mnemonic again for it is wrap an AC with stable spine. Okay, I usually learn in my like basic things, I always say learn it with your mnemonics. That's the reason I have made mnemonic for everything to make the learning part easy. Okay, so rotator cuff muscle strength you need to test. This R is for rotator cuff muscles. Okay, so how are you going to test? This is your supraspinatus. Supraspinatus, if you want to test, your arm should be in the scapular plane. Okay, fingers pointing down, and ask the patient to lift the arm, and you try to resist it. So the patient is going to have pain here, right? So we are testing supraspinatus. Fine. If you want to test infraspinatus and teres minor, and supraspinatus is the one which will be initiating the abduction. Okay, so we are testing it in abduction. Infraspinatus and teres minor, they are the external rotators. Okay, so we are now testing the external rotation. Okay, now internal rotation, subscapularis is the internal rotator. So how are we testing? Arm by the side of the body, elbow flexed, and we'll be asking the patient to move this two hands towards the body. Fine. Then biceps. Biceps is the flexor. Okay. So how are you supposed to test it? Your elbow should be extended, and we'll be asking the patient to bring this palm towards the face, and you apply the resistance. Fine. So you'll be testing that. Another test is Yergassen test. How you can do it? Arm by the side, elbow flexed, ask the patient to supinate, and you will be resisting it. Okay. Sorry, you will be asking the patient that he has to resist, he has to supinate against your resistance. Okay. Fine. Trapezius, again, ask the patient to shrug, and he has to shrug against the resistance which is applied. You will be applying the resistance, and patient will be shrugging the shoulder. For rhomboids, you ask the patient to keep the hand over the hips, okay, and try to squeeze the scapula towards the midline, okay, and the patient has to perform it against the resistance which you will be applying with your palm over the elbow, okay. Then serratus anterior, you can ask the patient to do the wall push-up, and you can just look for the movement of the scapula. Fine. So we have tested the rotator cuff, we have tested the biceps, and we are just testing the additional muscles. Some more muscles we need to test. One is your pectoralis major. This is the adductor of the shoulder joint. So again, we will be asking the patient to put the arm in your scapular plane, and then again try to bring it internally rotate, okay, and then try to bring it towards the midline against the resistance which will be applied by you. For anterior deltoid, you need to do the push. You need to ask the patient to push your palm, and you apply the resistance. Why? Anterior deltoid is it basically is a flexor of your it is basically causes the forward elevation of your arm. Okay, so you can test it like that also, but usually in all the orthopedic books and all, they have just mentioned this test, and it appears to be very good. You can just see the muscle which is contracting. Now the middle deltoid is an abductor, okay, and the middle deltoid takes its function from 45 to 60 degree, okay, and then up to the 90 degree is the deltoid which is working, which is just abducting. So if you want to test it, you need to test the abduction. This is how it has been tested. So I will be showing you, so just don't worry about it. And the posterior deltoid is an extensor, okay, so you need to test the extension against resistance. Fine. Now we have tested the rotator cuffs, we have tested the additional muscles, okay. So R was over, A is over. Now P, wrap. So this P is your painful arc. What is painful arc? Just understand it very nicely, because this is very, very important if you are looking for any impingement. So ask the patient to do the abduction from your 0 degree up to your 180 degree, okay. So if the patient is complaining of pain in the mid arc, okay, so 45 to 60 degree, if the patient is complaining of pain, we are going to think of any subacromial impingement, okay. So again, the patient is not going to have pain. And again, if the patient is saying, no, at the top of this, I am having pain, so think of any AC joint pathologies, okay. Now we have tested the painful arc. These are 3 tests, okay, for your impingement. So Neer test, Hawkins-Kennedy test, and subcoracoid. Neer's test, we are testing the impingement of your greater tuberosity. So what we need to do is, we will passively elevate the arm in the sagittal plane, okay, forward elevation of the arm in the sagittal plane. So once you do that, the patient will be complaining of pain. Hawkins-Kennedy test is, you abduct the arm, okay, you do the internal, you flex the elbow and do the internal rotation. So again, if the patient is having any sort of subacromial impingement, the patient is going to complain of pain. Subcoracoid impingement means there is an impingement of your subscapularis muscle beneath the coracoid, okay. So now we need to test it. So we need to test it. The test is known as subcoracoid impingement test, and this is basically a modification of your Hawkins-Kennedy test, okay. So what we have done in the Hawkins-Kennedy is abduction, flexion, and internal rotation. What we do here is, we will be doing the forward flexion, okay, little minimal internal rotation, and then we will be bringing the arm, in an adducted position. So now the lesser tuberosity will be coming in contact with your coracoid, right? So if there is an impingement, the patient is going to complain of any anterior shoulder pain, okay? Fine. Now, if there is a problem with the AC joint, you need to do this test. What is that test? Pexy-Noss test. What you need to do, you hold your clavicle with your 4 fingers and you put your thumb over the spine and try to squeeze. Means you're just bringing the clavicular posterior, right? So the patient is going to complain of pain on the top of the shoulder. This is the way, modified version of doing the same. If you are not able to perform it, like suppose if an obese individual has come, so you can just clasp your hand and try to put pressure, over this clavicle and the acromion. Fine. So that was about the AC joint. Now there is one test which is O'Brien's test, or also known as active compression test. What we do here is, this test is basically the one which will be distinguishing between AC joint pathology and slab lesion. AC joint, we have this test. Other than the test, if you really want to go for, you can go for a single test. So that is a single test which you can go for, and this will be basically differentiating between whether the pain is from because of a slab lesion or it is from the AC joint. What you need to do is, your forearm will be in your forward elevation, your this limb will be in your forward elevation, okay, and then you will be doing 10 to 20 degree of adduction and full internal rotation. Now ask the patient to lift this limb against resistance, okay. So the patient will be complaining of pain. But before that, you need to explain the patient where exactly he is feeling the pain. Supposedly, the patient says, I'm feeling the pain at the top of the shoulder. So it is the AC joint pathology. If the patient says, doctor, I'm not able to locate where exactly I'm feeling the pain, but I feel it is coming deep inside the joint, of a slap lesion. And as soon as you will turn the finger, as soon as you will externally rotate and you will ask the patient to lift, the pain will go off. Okay, so then this test is, we say that this test is positive. Okay, so AC joint we have tested, and we have also ruled out the slap lesions. Now, instability, which is very much common in the younger individual. So there are two tests, very easy test. Very easy test for you, okay, to test the instability. See, this is the patient. We will stand behind the patient, okay, and we will hold the clavicle, okay, and the scapula. Why are we doing so? So that we are stabilizing the scapula. So there won't be any scapulothoracic movement, right? So you stabilize that and abduct the shoulder. So abduct the shoulder and you will keep on moving into external rotation. Okay, as you will just keep on doing the external rotation, so patient will say, no, doctor, don't do that. My shoulder will come out. Okay, once the patient will say like that, what you need to do, you press, from this arm, you give an posterior force, the pain will go off. Again, you will just remove, the pain will come. So that is anterior apprehension test. And when you give the pressure, the pain will go off. And again, if you release the pressure, pain will come back. So that is anterior relocation test. Okay. Now we have three types of instability. We can have anterior, we can have posterior, we can have inferior, right? So here we have tested the anterior stability. Now, we are testing the inferior. Inferior is the easiest one. You ask the patient to sit with the elbow flexed to 90 degrees and try to pull the arm down, okay? With the arm down, what you will see, so you will be seeing the acromion here and the humeral head. So you will see a sulcus which will be appearing between these two, okay? So that is, the patient is having some sort of inferior instability. Now coming to the posterior instability, arm is in your forward elevation, okay, do a minimal amount of internal rotation and then abduction. Now what you need to do, just look at the arrow which is marked here, okay, you apply a force like this from the elbow towards the shoulder, okay, and once you apply that force, patient will say, no, my shoulder will come out. Then what you need to do, you from this position, you do the abduction, okay, and once you are doing the abduction, you will be feeling a sound that as if something has gone inside the socket. So that is for your posterior instability, okay? And then finally, of course, you need to go for a flexion, extension, rotation, and lateral flexion of your cervical spine for the completion's sake, which will be discussed further. And these are the references which I'll be sending you. You can read about this, from these books, even the page I have mentioned it. So if you want to read more, you can read from those books. So any questions from the history, or I'll just have a quick demonstration because they have to start their class also. Shrujana, slap lesion is superior, lateral, anterior to posterior. Okay, lesions of your labrum. We learn now fibrocartilaginous rim. So if you have a lesion of that, that is known as slap lesion. You have many types of it. Okay, you have like Bankard's lesion. Bankard's lesion means you have the micro fractures. Where it is present on the posterior superior aspect. Then you have the Hill-Sachs lesion. Where it is present on the anterior inferior. And if you are thinking of any labral tear or instability, we cannot help the patient much. Okay, the orthopedic surgeon has to take care. Where is our role? Our role is if you are having a degenerative arthritis, if we have a rotator cuff tendinopathy, yes. If you have a subacromial bursitis, we are the one who is going to really be very helpful to the patient. Okay. What is impingement? Okay. See, impingement is, you should have a smooth movement. If that smooth movement is not there, means it is getting stuck. Okay, usually if I will do my internal rotation, it should not be painful. Okay, so if it is painful, means there is something which is restricting the frictionless movement. Supposedly the bursa is like this, okay? I'll be showing you in that, what to say, what is that? Skeleton. So you will be able to understand it, okay? So just give me 5 minutes. I will call the volunteers so that we can have a quick revision of what we have learned, because shoulder, and believe me, whatever I have taught you today, you remember all this test, most of the diagnosis, you will be able to make it. Okay, there is no need to remember, because there are ample amount of tests, so many tests for even a single muscle, but these are more than sufficient because they have got a good specificity and sensitivity. Okay, so I have chosen the one which I am also doing, and believe me, with all this test, it will be very easy for you to frame a clinical diagnosis. And then we have our ultrasound, our stethoscope, so we can always find out, right? So just give me 2 seconds, I will be back. Okay. Is the skeleton visible? Anybody? Okay, let me pin my video so that you will be able to see it. Okay. So see, I'll show you in this so that you will understand it. See, usually if I am doing an abduction, okay, see, this is our greater tuberosity, this is our lesser tuberosity. This is the sulcus.
Small.
What happened, Dr. Mohammed? Any problem?
Small skin, madam.
You cannot see me.
Your skin is very small.
My skin is very small.
Yes.
I have pinned it. How is it possible? All of you are able to see it very small?
No, it's okay.
Yes, yes, madam. Very small only.
Actually, don't worry.
Big Jew versus finite.
The view should be in speaker view.
I'm in speaker view only. I have pinned it. I think I'm able to see only my screen.
Okay, ma'am. Now it is right.
Those who are not able to see, go to the speaker view. Okay. So you will be-
Now it's full screen, madam.
Okay. Fine. Okay. So see this. Okay. Actually, see, this is your greater tuberosity. This is your lesser tuberosity. Okay. So what I was telling you, what somebody was asking about the impingement. Okay. So see, if I am abducting my shoulder like this, okay. So if just show it here. So if I'm abducting my shoulder, this movement has to be frictionless, okay? But if I'm abducting my shoulder and this movement is not friction, it is full of, pain, means there is some pathology. The bursa, which was very thin, it would have enlarged. There may be some problem with the supraspinatus, that the gliding movement is not proper, right? So this is how, you look for the impingement. If you do the knee test, see, this is the greater tuberosity, okay? So if I am doing this, movement has to be very smooth, means it should go, it should come back, it should go, it should come back. But when I'm just lifting it, if this is impinging on the acromion and the patient is saying, no, I'm having pain, don't do this. So it means there is some problem. Voice is cracking. Is my voice cracking?
No, Kanchan, it is all right. It is clear.
I think those who have technical issues, they should correct it. Okay. Okay, fine. And then when I'm talking about this, see, this is your coracoid. Okay. So this is your coracoid, right? So coracoid, if I'm abducting, okay, I will just see whether this will allow me, because you have a spring here, but just see. So if I'm abducting and I'm just trying to see, so this will be my lesser, just show them from here, okay? So this will be the lesser tuberosity, okay, like this, okay? So this will be the lesser tuberosity, and this is coracoid. You have your subscapularis, which is coming from here and getting attached. So if I have a problem, if I do this movement, this will be painful. So these are impingements, okay? And now I'll be showing you all the movements on the volunteer. Stand there. quickly I'll show. Okay. So if you have anything, you have missed it, just give me a second. Okay. So we will start. I'll show you in both the planes. So just see this, okay, very carefully. See, this is the shoulder, fine. So what I am doing, I am elevating like this. Okay, so this is the forward flexion. I am doing it passively. Okay, now I will ask him to do it actively. And when you are with the patient, what you can do, you can make the patient stand like this. How I do, you make the patient stand like this. You stand here and you ask the patient, so do like this. Okay, supposedly the patient is able to do this much. Okay, do. Suppose he is able to do like this. So active is this much. Now what I will be doing, this is passive. Okay, so first always look for the active movement. Okay, so now we'll test this. Look how the forward flexion should be. Now do. So this is forward flexion. Okay, now we'll be showing you the extension. Okay, so arm by the side of the body and then he has to go back. So come here. Now it will be visible. Okay, go back. So that is your extension. Okay, now we will be showing you the abduction. Fine. So abduction. Okay, so now I have explained it. He will be doing it for you. Okay. So this is abduction. Now here itself, when the patient is doing, okay, so if the patient is having pain from here, okay, no pain from here to here, but the pain has started from here. Now it is going. Now there is a pain, okay. Now there is no pain and now again pain. So if he is having pain here, it is AC. It is AC joint, and if he is having pain from here till here. Somebody wants to say something? Otherwise, please mute yourself if you don't have anything to, ask me. Okay. So we have shown flexion, extension, abduction, and in fact the painful part. Fine. So now I'll be showing you the adduction. Okay. This is horizontal body adduction. Okay. This was abduction. Now he is moving it across the body. So this is adduction. Fine. Okay, now this is the normal range is over, painful arc is over. So we will be testing the individual muscles. Okay, so individual muscles, this is your coronal plane. Okay, this is your sagittal plane. Please mute yourself. Who is this? Who is unmuted? Sachin, Dr. Sachin, he was the one. So Sachin is now going to give me a chocolate. Okay, because he has unmuted himself. Okay, so this is your coronal plane, right? And this is your sagittal plane. What we have learned from the coronal plane, if you go 20 to 30 degrees forward, you are now in the scapular plane. Okay, so this becomes the scapular plane. If you want to test the supraspinatus, ask the patient to move, to keep this thumb pointing down, go a little lower. Okay, because if you will go here, the dead joint will be the one which will be acting as an abductor. Okay, so go a little down and ask the patient, do not use whole of your palm, okay, just to give so much of pressure, just use 2 fingers. Ask the patient to lift it against the resistance which will be applied by you. So, okay, so this is how you should be testing the supraspinatus. We have learned the infraspinatus and the teres minor, they are the external rotators. How external rotation we are checking? We are asking the patient to keep the arm by the side, elbow is flexed, and you need to move it like this. Fine. So now, how you will apply the resistance? Only with 2 fingers. Okay. Or what you can do, you can put your fingers here, and you can ask the patient to move this hand like this. Okay. And you will be applying the resistance. Okay. This is how you test the external rotation. And if you keep your 2 fingers inside, let me show you. If I'm keeping my, okay, I'll come this way. So if I'm keeping my 2 fingers like this, asking him to bring these towards, okay, so that is internal rotation. So this is by subscapularis. If you want, there is one more belly press test. Ask the patient to extend the fingers, okay? He should not be flexing this wrist, okay? And ask this patient to press on the tummy, okay? Like this. So if a patient has got any problem, supposedly with the subscapularis, so his hand should be, the wrist should be in, the finger should be in extension, okay? So what he will do, he will try to use his wrist, he will flex his wrist, move the elbow back. So means subscapularis, there is a problem, okay? You can test it in that way, which I have taught you. And this belly press test is also for your, for your subscapularis, okay? Now I'll be testing the biceps. What we have learned, biceps, the elbow is in the forward elevation, okay? For a elbow, sorry, this forearm, this whole limb is in your, the shoulder forward elevation, elbow is extended, forearm is supinated. This palm, forearm is supinated and the wrist facing, this palm facing up, okay? So ask the patient to bring this towards the face, okay? This is the best way. So ask the patient to do that and you apply the resistance. Okay, so this is how you test. This is also known as speed test. Your Garson test is C. Elbow, this arm by the side of the body, elbow is flexed. Now the biceps is a supinator. So we are going to test the supinator action of the biceps, right? So if this is the mid-prone position, if the patient has to supinate, he has to do like this, right? So what you need to do, you need to apply the resistance. Sometimes I do like this, I hold it and then I apply the resistance like this. Okay, fine. So this is for your biceps. Now what we need to test is our trapezius. I'll bring the stool. Voice is not clear. My voice is not clear. Dipjyoti boss, my voice is not clear.
Clear, ma'am.
It's clear, ma'am.
For those if my voice is not clear, they are facing technical issues. Now see, I'm testing the trapezius. I'll ask the patient to shrug the shoulder. First, always explain. But now this volunteer, I've already explained him previously before the class, right? So I will ask him to do like this, okay? And you apply resistance. Do it. Okay, so while I'm testing the trapezius, fine. Now we'll be testing the rhomboids. So I'll remove the stool. I'll again make him stand here. Okay, I'll ask him to put his palm over the iliac crust. Okay, so I'll show you like this. Okay, so what I will do, I will ask him to squeeze these two things towards the midline. Okay, this one and this one, they are the scapula. This is our interscapular area where the rhomboid is going to be there. Okay, so and I will be applying the resistance here. Fine, so I will show you with this hand. Okay, I hope it's clear to you. Go there. Fine, okay, squeeze it. So you apply the resistance. At the same time, you can put your hand over here and look for the contraction in your rhomboids. Okay. For serratus anterior, I will ask him to do the wall push-up. So today he is going to tell you how to do the wall push-ups. Okay. So this is how he is going to perform. Now you can see. Yes, do it. Okay. And once he is doing, you have to look for the movement of this medial border of the scapula. Fine. So that was for the serratus anterior. And what is left now? Just a second. Now I'll be testing three more muscles. Pectoralis minor. So again, forward, elevation. Okay. Thumbs pointing down. I'll be asking him to bring these two together towards the midline. Okay. So do that. Okay. So I have tested the adduction. Fine. And then the anterior deltoid, make a fist, arm by the side, elbow flexed, and then I'll be asking him to push. So medial, anterior deltoid, I have tested. Now, this will be your, okay, we can test it like that. Scapular plane, thumbs pointing down, and I'll be testing now the adduction. Okay, So this was the middle fibers of the deltoid. Now again the posterior fibers. Okay, so I will be, okay, I'm not visible. I will be applying the resistance. Okay, so that is the posterior fibers we have tested. Okay, so that was all about the testing. Now needs impingement. I will show you from the back how I'm holding. So I'll be holding like that. Okay, so that I'm stabilizing the scapula. Fine. Now see, I have stabilized the scapula. I'm passively lifting the arm, going up. If the patient is having any impingement, he is going to complain of pain. I'll bring it here. Okay. Now I'm flexing the elbow. Okay, and I'm doing in. Wait. I'm doing an internal rotation. Okay, so this is Hawking's canary. If I'm doing it with an adduction, okay, minimal, minimal internal rotation. This was, I'm testing the internal rotation. I'm moving the arm. Okay, this one, see. And if moving, if I'm going towards the body, I'm doing the adduction, that becomes your subcoracoid impingement. Okay, so impingement test is over. Now what else is left? I think AC joint is left. So you sit here. What you can do, you can clasp your hand. This is the clavicle and that is the acromion. You can press it like this or you can press it like that. Okay, with 2 fingers. See, I usually find it difficult in doing that, so I usually do it. I compress these 2 with the clasp hand. Okay, then comes your O'Brien's test. O'Brien's test is again arm in the forward elevation, 10 to 20 degree of adduction, fingers down. Ask the patient to lift it. Okay. So if the patient is complaining of pain on the top of the shoulder, that is your AC joint. If he is telling that with this maneuver, I am having a pain inside this joint, deep inside the joint, that is your slap lesion. Okay. So now I think only the stability test is left. So again, I'm stabilizing the shoulder. My arm is in adduction, and now I will be rotating it externally. If the patient is telling me, oh, please leave me, I'm having pain, what I'm going to do, I will just apply pressure from this side. The pain will go off. Again, I will release the pressure, the pain will come back. So that is for anterior stability. Inferior, elbow flexed by the side of the body, and I will be trying to pull it down. So I'm not the patient, I will be trying to pull the arm down. Okay. So I will be able to see the sulcus, which will be appearing on the lateral aspect and the of the acromion and the head. Okay. Then I think anterior we have checked, the posterior. Okay. So for posterior, your arm is in forward elevation, elbow is flexed. Okay. Then I will be again stabilizing the scapula and will be pushing the force like this from there. If the patient is saying that I am having, please don't do this, this is going to be painful, I will be abducting it, okay, and I'll be feeling as if one sound will come and this will go inside. The thing which has come out is going inside the joint. Okay. Yes, somebody, okay, so many questions, okay. Impingement test positive means, whatever the subacromial thing, the space which we are having, I have explained you with that mannequin also. So whatever that space we are having, that space is now reduced. Movement. Now the movements are full of friction. So we need to find out what exactly is the cause for that. Okay. So that's what is like impingement means. The frictionless movement is not there. The space which is already there, now it is reduced. Okay, supposedly earlier it was 4, but because now the bursa has enlarged. Now because there is some problem with the supraspinatus tendon, so 4 has become 2. So there won't be the proper movement of the tendons, and the space will be reduced and the patient will be having pain. Okay, I think I have taken lots of time. It's already 7:45. So you have to attend your sono anatomy class also. So I'll be sending you the PDF, okay, of the presentation. Go through it. If you still have any problem, you are most welcome to ask me anytime, ample amount of times. I'm always there to explain you, to demonstrate you. Okay? I think Chinmoy boss, are you there?
We are starting.
Okay.
So we can
So
take a
just
2
go
minutes
through.
break. If
Thank you,
anyone
ma'am.
requires 2-minute break.
It's a very nice presentation. Thank you, ma'am.
Thank you so much. And do read the PDF, which I'm going to send you. Okay. I will be asking one question from everyone. So I have to prepare 100 questions. So I'll be
Okay, ma'am.
preparing 100 questions and asking each one of you.
Okay,
Okay.
ma'am.
Do read. And if you have any problem, I'm always there to help you out. Okay. Okay, boss. You can start.
পেশেন্ট ছাড়ো, নাহলে আমি এখন শুরু করে দেবো। হয়ে যাচ্ছে, everyone is waiting. 2 minutes break. I have already announced.
Hello, everyone can see the our volunteer or not? And also can hear me?
Yes, boss.
Okay. So we can see the patient. He is not a patient, of course. He's our volunteer. So he is sitting on a stool. So now I will be showing the ultrasound of shoulder. So few things. First thing is that what probe we are going to use. So this is the linear probe. I'll show here. This is the linear probe which we are using. Okay, so this is the linear probe. Okay, so we are using most of the things are not in shoulder. It is not that superficial that we can use hockey stick probe, and not that deep also that we will go for curvilinear probe. So this is our probe of choice. Okay, then we will see that please mute those who are not asking any question. So okay. So this question, this thing, sorry. So you will see that this aspect marker on this probe, and this aspect marker we will, I mean, this aspect marker corresponds to the left side of your screen. So while we will put our probe like this or this, whatever, we can know that which side is which side. Okay, I will tell you that also. Okay, then comes the position of the, while doing this ultrasound of your shoulder, there are 2-3 positions. Okay, so patient is sitting, you can do a shoulder ultrasound when patient is sitting. It is not done in a lying position or any other position. So yeah, please mute those who are talking. I mean, it's not good. So anyway, this shoulder, most of the time we will do ultrasound in a sitting position. And then what will be the hand position? So most of the time hand position is we will start, there are multiple hand positions, so we will start in this position. while we'll be seeing we'll start the first hour ultrasound of shoulder, we will start in this position. His hands will be like this, 90 degree flexed at the elbow. Okay, then some other positions are there. One is cross position and one is modified cross position. So this is cross position. Okay, in this way, when he will put this is the position. This is called cross position. So I will tell later that why we are doing this cross position. And modified cross position is when he will put his hand like this. So this is modified cross position. So let us see that. Just a minute. Jolfen.
So have you understood cross position and modified cross position? Or do you have some questions? No questions. Okay.
So let us proceed. I will show you in the ultrasound, and Dr. Devjyoti will annotate the things in the screen so that you can understand. Oh, and okay, then another thing, we are seeing the left shoulder of the patient, and so as we have understood that this shoulder has rotator cuff muscles. Okay, so there are 4 muscles in the rotator cuff, though there are some extra muscles, added muscles in the shoulder area other than rotator cuff muscles. So first we take that what are the rotator cuff muscles. Let us again see. So supraspinatus, this is the spine of the scapula. This area is the spine of the scapula. So this area, these areas are supraspinatus muscle. Okay, and this is the infraspinatus muscle. Okay, so from supraspinatus it will go from here to here like this here, because this area is the your greater tubercle of the humerus. One is greater tubercle, and here it will be lesser tubercle. So supraspinatus will go from the greater to the greater tubercle of the humerus, and then infraspinatus will go from this place to this place, just below the supraspinatus insertion. So there it is the infraspinatus. It will also go to the greater tubercle of the humerus. Another muscle below infraspinatus, there will be teres minor. This teres minor will also go to the greater tubercle, again just below the infraspinatus. So these 3 muscles will go like this. Supraspinatus and infraspinatus has an angle. It will go like this. So it is not exactly 90 degree, but then it is 60 to 70 degree angulation it maintains. It goes from here and here. Okay, then comes, so we can understand that here is the humeral head. Here is the humeral head, and this is the greater tuberosity and greater tubercle, and here is the lesser tubercle. So only one muscle goes to the lesser tubercle. Where from it will come? It will come from this side, here, from this side. This side, anterior side of the scapula, it will come and it will enter here. Okay, so here one tubercle, here one tubercle. So between these 2 tubercle, what will be passing? Here one tendon is passing, that is the biceps, the long head of biceps. Long head of biceps will be going between these 2 tubercles. Just a minute. So between these 2 tubercles, long head of biceps will go like this. Okay, so long head of biceps goes to where? Biceps has 2 heads. One is long head, one is short head. Short head goes to the coit process, and long head enters, goes like this and enters in the joint and blends with the margin of the capsule, joint capsule. Okay. I mean, like, this is the okay. So as I told you, there are 4 muscles. One is supraspinatus, infraspinatus, teres minor, and subscapularis. So these 4 muscles are the rotator cuff. Apart from this, what are the associated muscles? So one, as I have told, biceps. biceps muscle is not associated, but then tendon, insertion of the muscle, long head and short head. So these are coming in relation with the other muscles. So biceps is one muscle. Second muscle, here it is the trapezius. So trapezius is another muscle that is also coming in relation with the shoulder. Okay, third muscle is the main important biggest muscle, and that is the most superficial muscle, completely covering the shoulder from posterior side, lateral side, anterior side. So this is the deltoid. Whole muscle is covered by the deltoid. Okay, so this is the third muscle, and then coracobrachialis also is an associated muscle. So this will come from here and going to the coracoid process. So these are the associated muscle. Okay, so first when we start doing ultrasound, we will go with, okay, we will start from the in a systematic manner, so that we do not I mean, like, we do not I mean, lose our way. We do not go in a position that we do not understand that where we are holding the probe. And for examining also, you should have a one protocol in mind, so that you go in the right place. I will do ultrasound in this shoulder, because otherwise it is difficult for me, because machine is in the opposite side. Okay, okay. Okay, okay, okay. So this hand, yeah. So okay, first thing I am showing you. Hmm? তাহলে আচ্ছা না, একটু ঘোরাও, একটু এদিকে ঘোরো। হ্যাঁ, ওকে, তুমি ভালো করে, হ্যাঁ। So now left side of our screen will be medial side. This side is medial, so left side of our screen will be medial side. First, let me show you. This is what we are seeing, the first bony shadow. Let me tell you the bony shadow. So what is this bony shadow? This bony shadow is nothing but humerus. Okay, so first we can see that this is humerus. Now I'm gradually coming up. Okay, a bit depth increase. So you see there is a this bony shadow. Yeah, here also the single bony shadow. Okay, single bony shadow. As I am going up, this is becoming like a I mean, two shadows, and in between there is a gap. You can see there are two shadows, and in between there is a gap. Yeah. So yeah. So Dr. Devjyoti has marked. Devjyoti, you tell. So one side, medial side, it is the lesser tuberosity, and lateral side, it is the greater tuberosity. Okay. So again, I am showing the same place from here. You can see my probe. This is the humerus. When I'm coming up, and this is the two. We can see that in the middle there is a groove, which is we call the bicipital groove. Okay, this is the groove in between, and both sides there are two tuberosities. So in the middle left side of your screen is the lesser tuberosity, and right side of your screen is the greater tuberosity. Okay. So now, as I told you, that between these two tuberosities, there is a tendon. Okay, so we can show you the tendon. Just a minute. You can see clearly, but then freeze. Okay, okay. So this is the bicipital long head of biceps. Bicipital tendon. This is the long head of biceps. Bicipital tendon is going like this between the lesser tuberosity and greater tuberosity. Okay. So I am showing you again. Okay. Okay. And while doing ultrasound, always keep in mind there are in every patient there is some anatomical differences. There are some anatomical variations. If no two patients are same, I mean most of the time it is very common. It is not that I mean these variations. Hmm? Okay, 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 okay. So it is not that the variation is uncommon. So we see most of the time. Hmm. So here also our volunteer's shoulder is a bit different. So again, just you see humerus gradually, I'm coming, and it is the two tubercles, and just above this, it is the tendon. Okay, this is the big bicipital tendon. Okay. Now there are one thing is that this tendon is looking hyperechoic, but it is how you hold. I can make it hypoechoic also. So this is becoming a lot of portion of this tendon becoming hypoechoic. See, now this is hypoechoic, and if I just tilt, this becomes hyperechoic. Okay, this becomes hyperechoic. Yeah, now the tendon becomes hyperechoic. See, very nice hyperechoic structure, and I can make it hypoechoic also. So what is that? What does that mean? That is actually that is called anisotropy. Anisotropy means it is actually it should come hyperechoic, but since you are not holding your probe at a 90-degree position to the muscle fibers, to the fibers of the structure what you are seeing, that's why the adequate number of reflections are not coming to your probe, and you are seeing the things black, that is hypoechoic. Now you see the beautiful hyperechoic thing, and if I hold like this, it looks like totally hypoechoic, as if the tendon is not there, it is empty, black. But then if I just hold like this, the tendon appears. Okay, so this is hyperechoic tendon. Okay, so now I will show you the long axis. This is the short axis. Short axis and long axis, always remember, that is relative to one structure. Whichever structure we are referring to, our short axis and long axis is referred to, I mean, in relation to that. So biceps we are seeing at a short axis view here. So now I will make biceps in a long axis view, biceps tendon, long head of biceps, I will make in a long axis view. So I will put it in middle, and I will move my. So this one is the biceps tendon. Just a minute. No, it's not there. It's moved. It's okay. Ah, ah. Okay. So this is where we are seeing inside the groove. Inside the groove, one side it is greater tuberosity, one side it is the lesser tuberosity, and this is just inside the groove. The whole tendon we can see that it is directly straight way it is going, and this is the long axis view of the long head of biceps tendon. Right. So okay, so again I show you here. So this is the long axis. Okay, so if I go a bit medially, what I will see, the lesser trochanter, lesser tuberosity. Medially I have gone, and this has become the bone shadow, lesser tuberosity. Okay, this is the again become the middle groove portion, and if I go laterally, again it will bone will come. This is the greater tuberosity. Bone will come, and there is no tendon. Okay, so greater tuberosity, tendon. This is the tendon, and this is the lesser tuberosity. Okay. Then, oh, okay. Another thing is this, we can trace it that where the tendon is going. So we can trace up to this much. After that, it goes inside the joint. So say this much, we can see. And after that, it is goes inside the joint. So that will not be seen. And after that, it doesn't go straight. It goes to one side. From it comes like this, and then go to just tilt like this. Goes one side. So I mean, if you put the your probe like this, you will not be seeing the in a sagittal section in a long axis of the upper part, because upper side part is curved. Okay. Then we see the subscapularis tendon. We start subscapularis muscle and tendon, which is in the rotator, which is a part of rotator cuff and starts from the anterior side. And while seeing this subscapularis, we will be also seeing the trapezius deltoid muscle, because that is the most superficial, and below that only subscapularis, supraspinatus, infraspinatus, those things. So left side of your screen, it will be the medial, left side of your screen will be the medial ear. So again, I am coming in the medial of the patient. So here, let me freeze. Okay. So Dr. Devjyoti will show you which is the subscapularis muscle. So this is the lesser tubercle, lesser tuberosity, and this is the whole subscapularis muscle. Though subscapularis muscle is entering, I mean inserting in the lesser tuberosity, and only a small portion of some fibers goes above the biceps tendon and goes to the edge of the greater tuberosity. Okay. So this is the subscapularis muscle. Now we can see a lot of subscapularis muscle. If I change the position a bit. So as you have understood, we have started from here, biceps tendon and all we have seen clearly, and then we are going medially, more medially, to see the subscapularis muscle. Now this is the subscapularis muscle, but this part here also some amount of anisotropy will be always there. Why? Because subscapularis muscle coming like this and entering like this. Okay, so if it enters like this, coming after coming like this, then putting our probe in a straight manner will not be at a 90-degree angle to the tendon of the subscapularis muscle. So we have to do some heel toe maneuver like this, to see the subscapularis, tendon in a hyperintense area, hyperechoic structure, as a hyperechoic structure. Here you can see if I put like this, okay, so then some part of the tendon is of course looking white, which is the normal but then medial part it is black. That is due to anisotropy. As I do this this one, your heel toe maneuver, then the most part of the tendon becomes white. So so then I have, in this position, I have to see the tendon and I have to see that whether his tendon is all right or not. Okay. And remember, every tendon, while inserting in a bone, takes a butt pick appearance. Okay. That is not only for supraspinatus, for most of the tendons, it is like a, while inserting in the bone, that is a butt pick appearance. Okay. So which one is butt pick appearance? Dr. Devjyoti will, so now we will show a bit more of the tendon. Okay. Okay. So we have seen the lot of tendon part. So if we go medially, we will not be able to see because of coracoid process. Coracoid process will stop us. This big projection like thing is the coracoid process. Okay, this is the coracoid process. Just above we will come. This is the bone, and this is actually the short head of biceps and coracobrachialis, of course. But then the muscle is going below that, below coracoid process. We will not be seeing. So what we can do to see that that part, we will tell the patient to move his hand outside, external rotation, putting the এরকমই রাখো। So we can see a lot of muscle has come out from the below the bone. So it has come till here below the bone, and these are the muscle. So there we can see some slits, some black and white areas. Okay, so what are these things? So these black and white areas are the myotendinous junction, some slips of muscle. First upper part is black, white, you can see. So these are myotendinous. Medially is the muscle, and this from this junction tendon starts. So these are the myotendinous junctions. Okay, so while seeing the a muscle, you have to see the full length of the muscle. Okay, you have to see the full length of the muscle. So this is the full length. This lesser trochanter has moved externally. So this has become the your I mean bicipital groove here, and these are the full total lesser tuberosity, and we can see the a lot of muscle here. Okay, but till myotendinous junction we can see. So this is very clear, and the tendon we can see the tendon is hyperechoic tendon. Most of the part is normal. While seeing, also we will notice that though he is our volunteer, but still we will always see that cortical margin of humeral head, and we can see there is some irregularity on the cortical margin of the humeral head in our volunteer also. So that is possible. If that is painful, then he of course we will go for a diagnosis of tendinosis, and we need to treat that. But here this is a, I mean, chronic thing. I mean, he doesn't have that complaint. Okay, so this subscapularis muscle we have seen. So always while seeing, you have to see the tendon and also the bony contour, that whether it is typically round and there is no disruption of the cortex, that also we have to see. And most of the time, if there is a tendinosis or something that is near to the bony disruption, that is near to the bony disruption, then it is the actually articular side tendinosis, and if it is on the other side, that will be bursal side of I mean, like disruption of the tear, of the tendon tear. So okay, so these muscles, we know that this is the biceps muscle. The most superficial one is the biceps muscle. Okay, most superficial one is the biceps muscle. Okay, then let us go to the next step. So we have seen that this is our subscapularis muscle is coming from the medial side and joining in the lesser trochanter. Oh, we have not shown you that subscapularis muscle in a short axis view. So I show you in the short axis view also. So as I told you that this is the biceps, this is the lesser trochanter, and our subscapularis muscle will be this is the subscapularis muscle. Just wait. Yeah, this one. Let me decrease the depth. Okay. গন just wait. একটু দাঁড়াও, সুন্দর করে এই যে ইয়ে করো তো, ফ্রিজ করো। Okay. So this is the subscapularis muscle. Again, the myotendinous junctions, what we showed in the long axis view of subscapularis. This is the short axis view of subscapularis, and it is the same myotendinous junction. That muscles are black and tendons are white. So this is also normal. You should know while I mean scanning the subscapularis muscle, this structure, if it comes, then you will understand that this is a normal thing. Normally this is seen. Okay. Okay. And so this will come like this, and this comes to the ultimately it joins to the lesser tubercle. So that is okay. Now we are going to the supraspinatus muscle. So where from supraspinatus comes? Supraspinatus comes from here and it should join here. We have an idea that where supraspinatus can, where from supraspinatus can come and can join. Okay, so if I put my probe like this, then first what we will see here, as I told, the muscle, superficial muscle is trapezius, and then below it is the supraspinatus muscle. Okay, trapezius and supraspinatus muscle. Medial side is left side of your screen. If I go like this, it will be medial side, and if I go laterally, that will be in the right side. So from at this point where it is bone here, acromion. So after that, also, so this supraspinatus muscle comes from here and gradually it goes under the acromion and again comes out here to join in the greater tuberosity. So if I can, you see supraspinatus is the lower one, not upper one. So lower one is coming like this, then bone comes, so it cannot do it, we cannot see anything. Then again the supraspinatus is out. Okay, so this is the supraspinatus. And above muscle is deltoid. This side is deltoid, this side is trapezius, and lower muscle is supraspinatus. Here also bone, and this muscle is coming out. So this is supraspinatus. Okay, and it is joining to the greater tuberosity. I mean greater tubercle. Okay, so this is the supraspinatus. So okay, so this is the supraspinatus. Here also it joining as a in a Bart peak appearance. Here also it is taking a Bart peak appearance. So just wait. Just show this acromion and greater tuberosity. Yeah, greater tuberosity, acromion in the left side, and the supraspinatus is coming from below the acromion. So this is the so that is the most important area for subacromial space, which is important for your impingement syndrome. So how it is important? So now I show you a. So as I last time I mean like now we showed that more part of subscapularis can be seen if I do external rotation of the hand. Now if I want to do want to see the more part of supraspinatus, then what I need to do? Then comes the importance of cross position. Yeah, gradually. Okay, slowly, so people can see that a lot of supraspinatus has come out. See, a lot of supraspinatus has come out. So these are all supraspinatus. Okay, so these are all supraspinatus. And here also the same thing happens, that Bart peak appearance also there. And okay, first I show you the musculotendinous junction of the supraspinatus. So in left side under the acromion, a small part of acromion you can see. So this under the acromion, the musculotendinous part of the supraspinatus can be seen. Muscle is black, tendon is white. Okay, and when I will again show that this same thing. So the same thing you can see, and here also one articular cortical disruption you can see, cortical irregularity. So this is also not common. Okay, though he is our volunteer, but you can see in normal position, normal person, you will see cortex like this. Yeah, those who have no articular, I mean like corticular disruption, their cortex will be like this. Okay, but here cortex, a bit of disruption is there. Okay, so if I need to see the okay, first thing you see that where it is inserted. So where it is inserted, this is more or less inserted here. Okay, so this is the greater tuberosity. This is the greater tuberosity. Okay, this is also, there is also a bird peak appearance. Okay, and if we want to see more, I mean whole breadth of supraspinatus, then I will go like this. This is the end of the supraspinatus. After that, subscapularis comes. This is the end, and from here to here, because after that infraspinatus comes. So this is the supraspinatus long axis. Okay. Yeah, this is the supraspinatus long axis. Oh. Okay, so this is supraspinatus we have shown you. Okay, short axis, there is nothing much to see. If I just hold like this is the muscle belly of supraspinatus. Upper part is the actually clavicle, and lower part is the your spine of the scapular spinous process. Okay, so but this muscle, the whole muscle belly is supraspinatus. Lower part is supraspinatus and upper part is trapezius. Okay, so okay, so supraspinatus also we have seen. Now I will show, yeah, not needed. Yeah. Now we will see the infraspinatus part. So you remember the position of your hand. Yeah, I'll show. So now you remember the always with the structure. Remember the position of the hand. So supraspinatus we use the cross position again in the infraspinatus. So infraspinatus we know that just below the spine it is the infraspinatus. So we'll put our probe like this, and what I see here is our infraspinatus muscle. Just a bit, yeah. So lower part is the bone. Lower part is the bony scapula. Okay, and this is the totally infraspinatus muscle. Lower part is the bone. Upper part of the upper part is trapezius, and it is infraspinatus muscle. Okay. So here you see, what do you see? So this is the infraspinatus, bone is coming like this. Just a minute. So this is we are following the infraspinatus muscle. So here we will see the tendon of the infraspinatus, and here also we can see the tendon is going to the greater tuberosity to join. But then here also, if you want to see a bit lot of more tendon and more muscle area, then what we need to do? Then we need to internally rotate. From subscapularis we did external rotation. This is internal rotation. Yeah, just check. Wait. Yeah. Yes. Now internally rotate. Okay. Earlier it was like this only. না না আগের মতো রাখো একবার. Okay. Okay. Right. রাখো. So okay. Yeah. This was the muscle. This was the muscle, and this is the tendon. This is the tendon. White part. White part is tendon. Okay. White tendon. So this is the tendon. Okay. Now he will rotate, and we'll see a lot of more tendon coming. Okay. So more tendinous part is coming, and this part is the musculotendinous junction. রাখো না ওরকম. Okay. So a lot of tendon part is coming, and other part is your musculotendinous junction. There. It's a bit sleeping. So Okay, so yeah, Dujiti, just freeze. No? Okay, so infraspinatus, this is the tendon, and this is the musculotendinous junction, white and black. Black part is the muscle, and this is the tendon. Okay. Now comes the teres minor. So teres minor is basically here also left side medial. First we will check the infraspinatus. Infraspinatus. This is the infraspinatus, and it is going like this, as I showed you. Now, if I come below infraspinatus, then actually teres minor will come from here. But then it is very difficult to identify the teres minor here. There is another way. If I show you a longitudinal, a long axis view in the humerus like this, then you will be able to see the teres minor here. Just a minute. Okay, so if I put a, this is the humerus. Yeah, so this is the humerus head. This is the humerus head, and upper side is head and lower side is neck. And just at the neck, there is a muscle which is ultimately becoming a tendon and going down. But then if I trace this muscle, so this is the teres minor. Okay. Okay, you can see or not. Ah, this mark this muscle. Okay. So at the neck portion, okay, freeze. Okay. So at the neck portion, you can see a muscle. So this is the teres minor. So uh, just try to, again, I will show you the muscle and just try to walk, I mean, like follow that muscle. This is the teres minor muscle. Okay. So this is very easy from here. As soon as it is coming like this, so there is a belly, I mean, this rightmost portion is one muscle, and there is another belly coming. This is the infraspinatus muscle, and lower part is the teres minor muscle. Okay, here there are two muscles. I mean, it is a bit difficult. Again, I show you here. So this is not very much important for our okay, so this is the upper part of the muscle, is the left part of the muscle is the infraspinatus, and this right part is of the muscle is the teres minor muscle. But of course, this is not that important. Okay, so this is the there are two bellies. Yeah, this belly and this belly. And it a brutal. Okay. So now I will show you the rotator cuff muscles has been shown. So now,
Chinmay boss,
yeah,
some of the participants, they want to see the probe from behind. How are you actually moving the probe? Just to look for the supraspinatus and infraspinatus from
okay.
behind.
Okay. Infraspinatus, this is the spine. Okay, I can feel the spine here. So just put like this. So what you see is infraspinatus. Left side of your screen is in the medial side. Okay, so here the lower one is the cortex. Okay, lower one is the cortex of the bony shadow. I mean, simple bony shadow. So okay, this is the uh, infraspinatus. Okay, infraspinatus. Okay, this is the infraspinatus, and if I go here, this will be the tendinous insertion. Yeah, this is the tendinous insertion of the infraspinatus. Okay, if I ইয়ে করো, একটু ভিতর দিকে ঘোরাও। হ্যাঁ, so see more of a infraspinatus tendon is seen, much more. No, a black part is the muscle from where the white part starts, that is the tendon. So if he comes in the normal position, then tendon will become a bit normal, a bit thicker, and this is the tendon. Okay, so infraspinatus or supraspinatus also someone wants to see. Supraspinatus, there is nothing, of course there it is there, but most of our procedure and all, it is after the acromion. Before the acromion, it is the supraspinatus muscle. This is the bulk of the supraspinatus. So that is not for not much of importance for us. Okay, this is the bulk of supraspinatus, but after acromion, when the supraspinatus comes out, so that is the most important thing. Okay, so here only impingement syndrome and everything will occur. Then how impingement syndrome occurs? So when, as Dr. Kanchan showed you, that during abduction patient will feel pain. Now you see, so he is abducting, what is happening? Now at this point, when the head of greater tuberosity just goes below the acromion, okay, so there only patient feels pain. That is the impingement syndrome. Okay, come down gradually, come down. So again it is coming out. Okay, so it is now it has come out. Okay, so that point is the normal. Okay, so again I show you, if you have understood. Okay, it is going, it will go just below the acromion. Here only a bit more. Here only patient will feel pain. Okay, it is this insertion of the greater tubercle under the acromion will not be smooth. That is the area where impingement will occur if the subacromial space length of depth, width of subacromial space is not adequate. So what is the reason why the width will go down? If there is a osteophyte coming from the acromion, and there are other reasons also you see in theory why the distance of subacromial space decreases. Okay, so this is one impingement. There are other impingements also. So another impingement is, as I told you, this is the subscapular is going under the coracoid. Okay, subscapular is muscle going under the coracoid. So here also one impingement can occur. Okay, this area where again now come out again moto koro erokom. See, this is the lesser trochanter. This is his normal hand position. Okay, if he rotates, internal rotation, if he does, okay, go go. Lesser trochanter is going inside the coracoid process. So at this position, this movement may not be smooth and patient may get pain. So this is another impingement of the subcoracoid impingement. Okay, so I think you have understood this one. Yes, na? Okay, now let me show you. Another important thing is bursa, subscapularis, not subscapularis, subacromial subdeltoid bursa. So where is the location of bursa? We will see the supraspinatus tendon, because ultimately supraspinatus is in the subacromial space. Okay, and I will make it more depth, decrease. Okay, so you understand this area. To modified class position. Hmm? No, I want to show them more. Okay. More stop করতে হবে। দাঁড়াও, তুমি stop করো। দাঁড়াও 1 minute. Stop. Okay, you can recognize this area. I have uh, zoomed it because in a normal patient where there is no subacromial bursitis and there is no fluid as such, it is very difficult to see subacromial space because subacromial bursa is a potential space. There is no fluid as such. So it is very difficult. But here we can see a small line. Is it down? Is the line down? Oh, this one. Okay, so this is a subacromial space. Okay, so if there is a subacromial bursitis, fluid is there, then we can aspirate or inject steroid there. Okay. Okay. Now comes, let us see the joint, glenohumeral joint from the posterior side. So we will see the infraspinatus. So again, I will increase the depth a bit. Otherwise you will not be able to see anything. So this is the infraspinatus muscle and lower down is the scapula bone. So bony shadow is there. This is below also bony shadow. You are seeing something that is mirroring effect, artifact. So this is the bone, and let us see here. So what do you see here? It's okay. So this is also a subglenoid fossa. Subglenoid, na? Spinoglenoid fossa. This is the spinoglenoid fossa through which the you just mark this area. No? Spinoglenoid fossa through which the articular branches of suprascapular nerve comes. If we want to block the suprascapular nerve here at the spinoglenoid fossa, then only sensory branches will be blocked. Then we can see the joint. There is two parts. One is the acetabular labrum and one is the acetabulum bony margin. We can see the acetabular bony margin. Yes, yes, and then the joint also we can see. Arrow we can. Yes, yes. So this is the joint area. Here, just above the articular surface of the humeral head, there is this small black line of cartilage also. So while injecting, we will not hit the cartilage. We will just go above the cartilage. Okay, I show you again. So this is the infraspinatus. When we are going medially, this is the first we will get the spinoglenoid fossa for the suprascapular. Yeah, seen. Vessel is seen and vessel is pulsating. Just you see. If I want to give color, it will not be shown probably very. Yeah. Spinoglenoid notch, and you see the pulsating vessel is very clear. I think pulsating vessel you can see. So this area, in this area,
Vessel is drawn in red,
vessel is drawn in red and
nerve in green.
nerve in green. Okay, so this is the spinoglenoid notch. Okay, and medial to that is the acetabular bony margin and then glenoidal labrum. Okay.
Red is bony margin, blue is labrum.
Okay. Wait, blue is labrum and red is bony margin. Then this is the head of humerus. Just above the humerus, though this space and I mean like cartilage is together, but then you have to remember that there is a small articular cartilage also. So now I will show you if the patient moves his hand, then how your in acetabular fossa, how the head of humerus moves. তুমি এরকম এরকম করো আস্তে আস্তে how it moves. So it is moving. You are seeing the joint. Okay, above left. This is the head moving, and left side the acetabular bone is fixed. The head is moving. Okay. So here also in some just a minute. Okay. So here also one impingement can occur between the labrum and humeral head. Okay. এই জায়গাটা so this is the between the labrum and humeral head. This movement also may not be that smooth. Okay, this movement also may not be that smooth in a patient. Okay, so দেখি আবার ঘোরাও একটু আস্তে আস্তে. So these small movement of joint, not joint, humeral head is coming inside. I mean going inside and coming outside. That may not be that smooth in every patient and can cause one impingement. Okay. 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 So this is one type of. So as I showed you that spinoglenoid notch, that means this is the supraspinatus fossa continuation in the infraspinous area. No, I mean if I go just above the spine, then I have to see the supraspinatus fossa also. So this is the spinoglenoid notch. Okay, so if I go just above, I go from here to here, they can see, no? Okay, একটু এরকম করো। না, এটা দেখতে পাচ্ছি? হ্যাঁ, ঠিক আছে। Okay, okay. So if I go above, then what will happen? First, I will get the spine of the scapula. I mean, total black bony shadow, and then I will go a bit more. Then again, I will see the muscle. So let's see. So bone is coming. This is the black shadow over the spinous process of the scapula, spine of the scapula, and then I go a bit up. So I see the so I see the supraspinatus muscle and the bony shadow again, and see at the right hand side you will see a vessel pulsating there. Okay, let's see if I can. So vessel pulsating, you can see if I give power Doppler, sometimes it takes color, but not every time. Color Doppler will not take. Yes. So this is the supraspinatus fossa. Usually color Doppler is useless for this. If I give power Doppler, then sometimes it takes color. Forget it. Huh? Oh, actually. But anyway, this is the supraspinatus fossa, and this is the break of the suprascapular fossa. Okay, no, supraspinatus fossa. Okay, supraspinatus fossa, and here only we will see the vascular pulsation, and just beside the vessel there will be the nerve. Okay, and yeah, so this pulsation is very nicely seen. Okay, I think nothing much to see here. Very nicely seen pulsation. There is a ligament crossing above the fossa, and so you have to puncture the ligament and go below that ligament just beside the artery to block the suprascapular nerve. Nowadays we do suprascapular nerve block very less often because we have better, I mean, other things. So okay, this also, oh, another thing I have not shown, no, that is AC joint. So straight off. So AC joint, where is the AC joint? AC joint has to be seen from above the uh, I mean, like from the superior portion of the shoulder. Okay, so your clavicle is here, and from there acromion is coming here. So medial side is in the left side. Medial side will be your clavicle, and lateral side will be. So this is the clavicular acromioclavicular joint. So left side is the clavicle. Uh, yep, yep. Okay, so left side is clavicle and right side is acromion, acromioclavicular joint. অন্য শোল্ডারে হাত দাও আস্তে আস্তে উঠিয়ে ক্রস ক্রস এটা উঠিয়ে এখানে দাও ধরো so just wait so you see the movement how patient is moving. Oh, they cannot see. Hey দেবজিৎ না না opposite side of the shoulder. এটা একটু ঘুরিয়ে দাও হ্যাঁ 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 ওকে সো জাস্ট এ ডাইনামিক মুভমেন্ট আবার আগের জায়গায় আনো. This is the acromioclavicular joint. We will put our probe like this. We are seeing left side in the clavicular part, clavicular head end, and then there is the acromial end in the right side. And what uh, patient will move his hand to, I mean, like to the opposite shoulder, to touch the opposite shoulder. It is a dynamic test for AC joint. Okay, so what do we expect if there is an instability of AC joint? Any margin, either clavicular side or acromial side, will dislocate, will go up. There will be a difference. It will not be in the same line. It will go up and down. One margin will be up and one margin will be down in if patient touches the opposite shoulder. And if there is no dislocation, nothing, then both will be in the same line. So this is a dynamic test for AC joint. AC joint is covered by a ligament. So that is also acromioclavicular ligament. So below that ligament, if you want to inject, you have to go below that ligament and directly in the joint you can inject. Okay, so I think I have shown most of the things. So tell me if you have questions. কটা বাজে গো? 50? Okay, if you have anything to ask me, ask me.
Boss, Dr. Subbulakshmi wants to see the rotator cuff interval.
Rotator cuff interval, actually, okay, I show you, but then this is our in our advanced course. Not in the basic course. So first thing, you have to understand the concept of rotator cuff interval. That is, subscapular is coming here up to the lesser tuberosity, supraspinatus, infraspinatus, teres major, to going to the greater tuberosity. And actually every muscle, this whole rotator cuff is covering the joint. It is covering the joint like a what should I say, cover. It is a total cover. Okay, so that's why it is cuff, so rotator cuff. But then what is interval? Because there is a small gap where there is no muscle, and through which actually mainly biceps tendon, long head of biceps goes inside the joint. So if you want to like go inside the joint, you have to puncture the rotator cuff, any muscle, whatever, then only you can go inside the joint. But if you go just by the side of the tendon, biceps tendon, then you will reach in the inside the joint without puncturing anything. Okay, so that is why that is the interval to go inside the joint. Okay, so rotator cuff interval, nothing but left side. Okay, left side, this is the shoulder subscapularis. Okay, in this view only I show. So okay, wait, so a bit of this one. Rotator cuff interval is shown like this. Okay, এই ব্ল্যাক এরিয়াটা দেখে দেন। হ্যাঁ Oh, okay, this one. Otherwise, they will not understand. Yeah, this one. Okay, okay. Ah. So one side is subscapularis, one side is supraspinatus. In between, it is the biceps tendon. Just entering in the biceps tendon in the groove, this biceps is going down actually, down and medially, and just beside the biceps, you see there is a space, black area. This black area is nothing but the empty space. Okay, so if I give an injection to this in this empty space, so that fluid will track by the side of the biceps tendon and will directly reach inside the joint capsule. So that is the rotator interval. Rotator interval, use of rotator interval is go inside the joint without puncturing anything. It is a natural interval. Okay, so that is the thing. So this space you have shown, no? Yeah. Okay. Okay, any more thing? Okay, okay, then I think enough time has passed, so let us call it a day.
So if there is no question, I think if you have a question, you can mail us. And remember, next week again there will be Kahoot, and in this Kahoot, that whatever discussed today will be there. And okay, that's all for today. Bye.
Good night.
Good night.
Bye. Good night.